This time on The Procedure. We are all born with a hole in our heart. While necessary during the developing stages in the womb, this hole between the upper chambers becomes unneeded after birth. For most, the hole closes, but for roughly 25% of the population, it never does. Most of these people never know they live with this hole, called a PFO. No symptoms, no medical problems. Yet for an unfortunate population, a PFO can mean life-threatening and debilitating events. If a blood clot forms and finds its way through this hole, it can lead to a stroke and even death. In the past, treatment for PFOs involved invasive open-heart surgery, but today, thanks to medical advancements and utter perseverance, these holes can be closed from within using a catheter-based device called an Amplatzer Pfo occluder. Join us as we take you live into the cath lab to see one of these procedures firsthand. See the technology, meet the pioneers, and see the lives that are touched with this groundbreaking technology. The procedure is made possible by educational grants from Abbott Laboratories and Siemens Healthineers.
And welcome to The Procedure. Dr. Reisig here with me. I am Brad Perry, your host.
Now, to disconnect it, it's very easy.
Okay.
We're just going to unscrew it like this, unscrew it, turn it to the left or counterclockwise, and there it is.
Oh, wow.
You've just successfully done this.
Wow, that's amazing.
You've just closed your first PFO, Dr. Brad.
Okay, who's the surgery benefit and how does it help them?
Unlike elderly people who may have a stroke because they have blood vessel disease of the brain, this occurs in young people. In fact, I want to share a story with you about a young woman who had blood vessel disease or vein disease of the lower extremity, developed a clot, a very healthy woman, worked out all the time, the mother of several children. I mean, this was a very, very healthy, active woman, and yet she developed one of these blood clots that crossed a PFO and it caused a stroke.
Let's take a look.
Okay, let's go get dressed for school.
You ate my necklace.
Doctors. Here. Hi, my name is Danielle. I'm 37 years old and a mom of 4 wonderful children. I'm an avid runner and live in beautiful Scottsdale, Arizona.
Boys, you want to go?
We have a very crazy schedule with sports with them. We are coming and going all the time between volleyball, baseball, football, you name it.
Say bye to mom, hugs and kisses, let's go, say bye.
I never thought something like this would happen to me. I was walking my kids out the door for school. My husband was taking them to school and felt, as I watched them walk away, I locked the door and I just felt this crazy rush go up my arm. It's really weird and I kind of leaned against the wall, but then as I did that, my head started like, whew, and so I was like, oh my gosh, something's happening. So I was able to unlock the door and get out front, but as I walk out front, my husband's literally pulling away from me in the driveway. So I went to go yell for him, and that's when I was like, oh my gosh, I know what I want to say, but I can't articulate a word. It's like, it was the only sound I could make. So then I started really panicking. I was like, I'm thinking of having a stroke.
My father died from a stroke, and so I'm really familiar with the signs of things like this happen, unfortunately. And so I was sitting in the driver's seat, and then I just see her.
Bailey started yelling.
Yeah, Bailey kind of, Mom.
She's fine.
She was like, look at Mom, and I kind of looked at Danielle, and she was coming out the front door, and kind of looked weird. I don't know. I've described this a couple times. It's like you're talking through your eyes, but you can't say anything. I could see that she was really struggling.
A PFO is a hole in the heart. That hole in the heart is necessary during your development in your mother's womb. However, once you are born and you start breathing on your own, a flap closes that opening. It was very clear that when you saw the ultrasound that there was a hole in the heart, and very likely that's where the clot had come from. This was just such a young, energetic, athletic woman, mother of several children, who recently had a baby, and really the thing that predisposed her to having a stroke was that she had chronic inflammation of the veins in her legs, a disorder called thrombophlebitis.
The fact that these things happened to her, I think, were a little bit,
Shocking.
yeah, a little bit shocking to us.
I was like, I don't want to get this done. Like, I don't want to. I'm fine. And like Dr. Isaac said, he's like, no. Once you have one, you're prone to more. And with age and with time, each one becomes worse. I remember being in his office, like crying and being like, I do not want anybody touching my heart. Like, I've lived my whole life without this. I've lived a fine life. I've had 4 healthy pregnancies. I've run. Like, I don't want it done. And he left the room. His daughter was there visiting, and he came back into the room with his brand new grandchild.
With his kids,
and put the grandchild on my lap, and he's like, this is why you need to do it. And I was like,
It was the perfect
it was.
it's like a teachable moment. Like, here, this is why we're doing this.
We began talking to her about performing a heart procedure. And if you begin to research it, you see that just a few years ago, this was an open heart surgery to have a Pfo closed. So we sat down with her and her family and discussed at great length that this was a minimally invasive, catheter-based, non-surgical procedure, and that we could probably do this on a Friday, and by Saturday morning should be ready to go home. The procedure went so smoothly. It was a picture-perfect closure, and we were all very pleased and very confident that she would never have this problem again.
Nobody should fear the procedure. It was so simple. It's amazing that they could fish this little like rolled up tube and open it up in your heart. It's just amazing. I was in the hospital, I think, only for a night, and then I was able to go home and I'm back to myself. And I'm better, and now I'm safe. I feel good now. I think I was touch and go for like that year after, like, oh gosh, did I feel something, or is it in my head? Or, you kind of second guess any little like weird cramp in your chest or something that happens, like, oh my gosh. But I'm so far past that now. I could run at high levels, I could race, I could do stuff that makes my heart rate get excelled, and I don't have any issues. I feel fine, and I feel back to myself mentally and physically.
We're going to see one more story, and then we're going to head into the surgical room ourselves.
And do one for real. Thank you, Bill.
Thank you.
My name's Steve. I live here in Jackson Hole with my wife and 4 kids. Absolutely beautiful place. 56 years old, and while I'm not a triathlete or anything, I keep pretty active with all the things that are going on here: skiing, snowshoeing, a little bit of rock climbing with the kids. I never thought something like this was going to happen to me. Over the years, I had 1 or 2 headaches, migraine headaches, maybe once every other year. So when the symptoms kicked in for this event, that's what I thought it was at first. I was walking upstairs to go see a doctor. My vision went black on one side. I sat down and I couldn't form a sentence. And after a few moments, it was pretty clear to both of us that something was really wrong, and they called an ambulance.
He had experienced a stroke, and actually, if you look at the MRI of his brain, the images of his brain, you can see that he probably had several strokes. It was more than one.
So I remember getting the call that he was in the ambulance on the way to the emergency room at the moment of the 3rd stroke. And I had no idea how minor it would be, how major it would be. So yeah, that was a very scary day.
The question really was, what was causing this? I had an echo of my heart done, which showed that bubbles were passing through from one chamber to the other, and that indicated there was a hole there.
A Pfo is basically a hole in the heart, and it's a hole that you need when you're developing in your mother's womb but that hole is supposed to close, and in most cases does close shortly after birth. But about 20 or 25% of adults have a residual opening or a residual hole, and most people don't even know they have it.
When I understood that it was a small blood clot that had gone through this hole up into my brain and had shut down parts of it, it's just a little alarming to think that it could have happened in a bigger way and possibly caused permanent debilitation. I'm extremely grateful that a solution to this problem was found. The procedure that I learned about through some spiffy animations is the Pfo Closure, where rather than chopping you open in the middle and having to break ribs and put you back together, that takes weeks or months of recovery, they could just go in through my leg, place the Amplatzer device. I mean, it's still spooky to go right into the middle of the heart to do this procedure, but you know, I had it done, 6 days ago, and after a couple days of rest, I'm pretty much back to doing everything I did before.
Steve's prognosis is fantastic. Steve is going to have a great quality of life, a full life, and the chance of Steve ever having another one of these strokes again is extremely low.
I think the outlook's very positive because he won't have to be on a blood thinner, and that was problematic, especially if you live in Jackson Hole, Wyoming, where there's extreme skiing and extreme mountain biking, and we have 4 children, and Steve was recommended to not participate in any of those more risky but super fun sports that our children do.
Yeah, I'm so grateful that they developed the technology to be able to do this. I never thought I had something going on in my body that could lead to a permanent disability. I think what I talk about with friends of mine is that if they ever experience something where they feel like their brain has sort of slipped out of gear, to get it checked, to get it looked at, and the fact that I recovered so quickly, within an hour or two, it really makes me think that people need to pay attention to these kinds of symptoms. I had no idea that I had had 2 previous strokes, really, because I think the symptoms then had been so small. If I had been watching television, I would not even have noticed it at all.
When he came into our bedroom and said to me, "I just want to let you know, I think something happened, it was really weird, we should have gone to a doctor right then. We shouldn't have waited for that 3rd stroke," which happened gratefully in a medical setting. But we're so blessed, there's been no difference, gratefully. I don't think there was any lasting effect of that stroke.
Oddly enough, I think I had a cognitive test done that showed some scores went up. But now I have a built-in excuse for where I put the car keys and forgetting people's names. I'm so relieved. I'm so relieved to know that at least, you know, we never know what's going to happen in life, but to know that this is something that's probably not going to be a problem going forward. It was just great to know that I was in good hands to get this done.
Doctor, an amazing story.
Isn't that something?
This is just incredible. If you're just tuning in, you are watching a live heart procedure here on AZTV7, and it is the procedure show. This is our 4th one with Dr. Reisig and his team here at Honor Health Shea. Let's introduce the room and who we have here.
That's great. Okay, so in addition to Brad Perry, who we always love having here, my partner for many years, someone that I just love doing these cases with, Dr. Mullick Shaw. Dr. Shaw is not only a superb clinician, he actually runs our entire division. Mullick, thank you for being here with us.
Thanks, David, for letting me join. Good morning, Brad. Good morning, David.
This gentleman back here is Dr. Kushi Agarwal. This is actually one of Dr. Agarwal's patients that we're going to do this procedure on. Dr. Agarwal, you're going to tell us a little bit about this patient in a minute. We have an incredible team. We have Dr. Burke. You know Dr. Burke from previous procedures. He's an extraordinary imaging expert. He's going to show us some fantastic images. Dr. Garcia is our anesthesiologist, again, a real superstar. And then the staff in the room, we have Erin, who's going to give us some x-ray images. We have Megan, who's sort of circulating the room and running around. She's getting her steps in today. And then I want to introduce this young lady right here. She is fantastic in every way. Brittany does many of these cases with us. She does a superb job. She knows what we're going to do before we actually do it. So thank you, Brittany.
Yeah.
All right. Let me orient the room, if you don't mind.
Yes, please.
The orientation of the room. This is the foot of the bed. This is the head of the bed. And if you look closely here, this is the access point into which we're going to place this device. It's non-surgical. We're not opening the chest. The device will go through this catheter, unlike if we were doing this procedure 20 years ago, which was an open heart surgical procedure. This is catheter-based, a minimally invasive, like keyhole in the leg.
Yeah.
And then we're going to get all kinds of nice images. We're going to deploy this with fluoro or X-ray images and ultrasound images that Dr. Burke is going to give us. And using both of those imaging modalities, X-ray and ultrasound, we're going to hopefully get a near perfect deployment of this device.
Yeah. And those at home, if you're trying to understand this, they're doing this all without opening the heart up like they used to crack open the chest and do. And it's really through sight with this team together, which is so important.
All right, now let me show you the device. Dr. Shaw, would you help me demonstrate the device?
Sure.
The device goes through this catheter. Dr. Shaw, explain what we have in terms of this device here.
Yeah, absolutely. So we're going to go ahead and plug in the hole that everyone's talking about, that Pfo tunneled hole. And this is the device through which we'll close it. So one side of this device will sit on the right side of the heart, and the other side will sit on the left side of the heart. One side is about 18 millimeters in diameter. You can see the smaller side, and the other side is 25 millimeters in diameter.
So it's really like a clamshell. It's going to purse string over that hole.
That's a great description of it, exactly.
Okay. A little bit about the patient. Dr. Agarwal, maybe you could tell us, you made the diagnosis, you first met this patient. Tell us a little bit about him and what happened.
Thank you, Dr. Reisig. This is a young man, a father of 5, a very hardworking man. He presented with, unfortunately, a stroke last November before Thanksgiving. He had left arm weakness, difficulty speaking. Luckily, he presented within a few hours of symptoms to one of our sister hospitals and was treated emergently with IV clot buster medications. Thankfully, it was a smaller stroke, and the majority of his neurologic symptoms resolved completely. In the ensuing months that I've had the chance to know him and meet his family, we've been able to show that he's got no inherent blood clotting disorder, which could be a confounding potential alternative reason for a stroke. He does not have that. He also had a loop recorder implanted in his chest. It looks like a paperclip. It's a continuous EKG, and it showed no arrhythmias of the heart.
Now, why is that important? Why is ruling out arrhythmias important?
And it showed no arrhythmias of the heart that could potentially be their own reason for a stroke.
So we have to rule out other causes before we just go and close the PFO.
And so now, through a thorough informed consent with multiple physicians, we're here today very optimistic for a great outcome long term.
So you made the diagnosis using a bubble test, correct?
That's correct.
Dr. Burke, show us what a bubble test is. How is it that we make this diagnosis? What does a bubble test mean?
So a bubble test is where what we're seeing here, and we can see this on the screen, you can inject bubbles into the heart, into the veins, and instead of staying on the right side of the heart, which would be over here, they can cross to the left side. And that's what we're seeing with this. You can see all those bubbles going through. This is the left side of the heart. This is the aorta, the main blood vessel to the body. And you can see how that gets all filled up with these bubbles. That shouldn't happen.
So in other words, that hole in the heart allows for that saline, those bubbles in the saline that we inject through a peripheral vein to actually cross, and that's how we make the diagnosis, correct?
Absolutely.
Okay.
Let me ask a quick question, because the doctor said something that's very important about this case, and that was this wasn't passed down through family members. This is something that he was born with. It just did not close, correct?
Very arbitrary. We don't think this is a genetic predisposition, not this specific type of hole in the heart. And Dr. Shaw and I were talking before we went live. We all remember some fellow student of ours in grade school or whatnot, who had to take time off from school because young man or young woman was diagnosed with a hole in the heart. So they went to some large referral center, some university center, and they had open heart surgery to close that hole. And now what we're going to do, we're going to get to the case now. We're going to close this non-surgically, without opening the chest as we did 2 or 3 decades ago, with just this catheter-based technique.
Wow, it's so amazing. Now, let me ask you this, Dr. Shaw. Does the heart know that there's something in there? Because that's kind of interesting where, we all have feelings of different things, but does our heart know that there's a piece of a new piece in them?
A piece of hardware.
Yeah, absolutely. The heart's very sensitive to everything, and that's why Dr. Ryzik highlighted all the equipment that's here. We're watching the EKG, we're watching the pictures, we're watching everything just to make sure that the heart's not getting irritated. And the heart oftentimes wants to form a blood clot or have an abnormal heart rhythm that results because of having this irritation in the body. But fortunately, with the newer generation devices, that irritation is a lot less, and the risk of having an abnormal heart rhythm that results from something like this is now minimal. So it's great because it truly is non-invasive and less risky overall.
I think that's the important thing, is that these devices have gotten so slick. And this is the Abbott Vascular Amplatzer Septal Occluder. And this device has gotten so slick. When you compare it to the older devices, this is just really a very, very easy deployment. It usually takes about 10 or 15 minutes.
Yeah, and that's one thing we want people to understand at home, is that we're taking you through this, but really the surgery is pretty quick to be done, you can say. I mean, it's very important, but it is, again, where it's not the open heart being here for hours on hours of doing this.
Okay, so you got to close one on the model, the acrylic model, the other day in the office. Dr. Shaw and I are going to close one now, okay?
All right, let's go through it.
All right, so Dr. Burke is going to give me all kinds of really nice echo images, and we're going to do this using X-ray and using the ultrasound. So I'm going to, Dr. Burke is going to guide me. Dr. Burke, is my catheter in a good position to deploy the smaller left atrial side?
Right now we're in a great position. The catheter, you can see right here, the tip is in the middle of the left atrium, and it's nice and free. There's nothing else around it, so there's no issue with anything getting in the way.
So now what I've just done, if you can see on X-ray, and I'm going to, if you can mag up the X-ray.
And it's important to highlight that Dr. Ryzik passed through that small hole with just with the aid of Dr. Burke's imaging and the X-ray imaging, because it's a minuscule hole sometimes.
So Dr. Burke, put your cursor, if you would, on, there you go, beautiful. That's the disc on the left atrial side. So we have formed the left atrial disc. Now what I'm going to do, actually what Dr. Shaw is going to do, is he's going to start pulling the device back toward the hole, slowly toward the septum. Let me get on fluoro here so we can see it.
I'm going to pull it back.
No, don't play. There you go. All right, come back with the whole thing. Dr. Burke, tell me when we're up against the septum. It looks like we are.
You can see we're up against the septum. That's looking very good. You can see this disc is nice and flush.
All right, now I'm going to form the right atrial side. Now, Dr. Burke is showing off a little bit. He does the best imaging of anyone in the country. He really gives me just such a beautiful target. So now I'm going to deploy the right atrial side, and there we go. So now the right atrial side is formed. Now I'm going to give another, there we go.
And it looks like that clamshell that you were describing with 2 discs on each side of that hole.
So the top disc, the smaller of the 2, is what we call the left atrial side. It's on the left side, if you will, of the hole. The bigger disc is on the right side of the hole. So they are going to purse string together on the hole to make sure that nothing can get across, no clots can get across in the future or anything like that.
So why is there 2 different sizes there on 2 different sides?
Because the older devices, the size of each disc was the same, and it used to irritate the heart more. There were some arrhythmias, but by making the left-sided disc smaller, there's fewer complications, fewer arrhythmias, less irritation of the heart. That's a very, very important distinction from what we were doing 10 years ago.
Wow.
Okay. Dr. Burke, why don't you show us some really good ultrasound pictures and convince us that we're in the right place and that now we can let this device go.
Okay, so right now we're seeing the device, and it's actually sandwiching the septum. That's that wall between the 2 chambers. And we've got the left and the right side here, and you can see it right there. Now sometimes you'll do that tug back and forth
And that's what I'm going to do right
going to go
now.
anywhere.
So I'm going to tug on it first, and it doesn't seem to be going through in one direction. Now I'm going to push on it, and it doesn't seem to be going through on the other direction. So Dr. Burke used the term septum sandwich, so that the hole and the wall that the hole is in is sandwiched between the two discs. I think this is a really good deployment, and I think it's going to benefit the patient.
It looks good right now on both sides, both on x-ray as well as on the esophageal echocardiogram.
So we use multimodality imaging. We use x-ray. Kind of guides me in a crude way, but Dr. Burke refines the imaging with ultrasound to give me great confidence, to give Dr. Shaw and I great confidence that this is exactly the place to deploy it.
Okay, so now that it's in there, and as you said, it's pulling them together, will the heart eventually close that hole, or is this the piece that will actually keep it closed?
This is going to keep it closed, but then the normal tissue of the heart is going to grow over this, so this becomes somewhat of an afterthought. Normal heart tissue grows over both sides, both discs, and the patient will never know it's there. You can see it on x-ray if he ever gets a chest x-ray or whatnot. He'll be able to see it, but no one will know, he won't know that it's there.
Will he, going forward, have to take any extra medicine or anything that he needs to do, Dr. Shaw?
That's great question. During the procedure, we give blood thinners to form that to make sure that no blood clots form on the device. And then afterwards, for a short period of time, we'll put him on what we call antiplatelet drugs like aspirin and a super aspirin. But after some period of time, oftentimes he can come off of these medications. And so this is a way to actually limit the number of medications needed, as well as reduce the amount of his risk for stroke moving forward.
Okay, so our priority now is the patient and getting this done. I think we can let this go, Dr. Burke. Do you agree?
Absolutely.
All
You're
right,
nice
so
and solid.
it is screwed on to this rod here. So we're just going to unscrew it, counterclockwise turn, and there it is. It's a perfect deployment. If you would push the table away from me a little bit, Aaron. There we go, and I'm just going to take a picture so they can see it, a nice clear picture. Beautiful deployment. You can see it's not moving. Now there's still another piece to go. Dr. Burke is going to take some ultrasound images and show us that this is now flush, flat against the septum where the hole is. Dr. Burke?
So again, we're looking at it. You can see how perfectly this sandwiches the septum.
Bob, would you put your cursor on it just
Absolutely.
to make sure they can see it?
So right here is the device. This is the septum between, and you got the left-sided disc and the right-sided disc. And this holds on perfectly. There was no blood flow through this, so when we throw color on there, there's no evidence of anything leaking from the right side to the left side anymore. And this is about as perfect as you're going to get.
Wow.
Wow. That's amazing to see that. And so let's talk about, as we are finishing up here, because again, going forward, or if someone's watching right now, what should they be looking for, and what type of things can they have done to check and see if they do have a hole?
Well, I think the first thing is it's the bubble study. That bubble study is extremely important. But Dr. Shaw, we don't do bubble studies on everyone, do we?
No, we don't. So it's important to take a step back and just recognize that unfortunately stroke is the 5th leading cause of death in the United States and the number 1 cause of disability. And so when people have a stroke, we start investigating why did they have a stroke. We look at their arteries and go into their brain. We look for atrial fibrillation like Dr. Agarwal highlighted, looking for abnormal heart rhythms. And when we can't find anything else, then we start thinking about, hey, is there a hole in the heart? And unfortunately, people who have a stroke are oftentimes more likely to have a small hole in the heart. And that's where when our antenna goes up to say, hey, maybe we should do a bubble study, or maybe we should look more closely to look for that small hole in the heart. And that's what Dr. Agarwal and Dr. Reisig did in this particular case for this patient.
So think about this. You have an 85-year-old patient who comes in with a stroke. That's probably not a hole in the heart. If they've had a hole in their heart all these years, it's probably going to show up before they're 85. But in this case, we have a gentleman in his mid-40s, a healthy young man working out, etc. Now, if your antennas go up then when you say a young person with a stroke, you better be thinking of a hole in the heart.